Good afternoon, everyone. Welcome to the webinar Clinical Guidance for the Management of Newborn Hyperbilirubinemia, presented today by Drs. Jack Rabi and Kathleen Hicks. The webinar is hosted by the Office of Lifelong Learning and Physician Learning Program at the University of Alberta. My name is Denise Campbell-Sharon. I'm the Associate Dean of the Office of Lifelong Learning and Physician Learning Program. Our office is committed to providing reliable updates and resources for clinicians, healthcare professionals, and everyone committed to providing the best care for patients. I'd like to start us off this afternoon with our territorial acknowledgement. The University of Alberta, its buildings, labs, and research stations are primarily located on the territory of the Navajo, Niitsitapi, Métis, Nakota, Dene, Haudenosaunee, and Anishinaabe lands that are now known as parts of Treaties 6, 7, and 8 and the homeland of the Métis. The University of Alberta respects the sovereignty, lands, histories, languages, knowledge systems, and cultures of all First Nations and Métis and Inuit nations. So just a little bit of housekeeping for the webinar. The chat feature in the bottom of the screen should be used for any questions that you might have about technical difficulties or any questions for L3 staff about programs or services. If you have any questions for the speakers, please use the Q&A feature of the webinar on the bottom of your screen. Please review what's already been asked and upvote those questions that you would particularly like to have answered. We cannot guarantee that we'll be able to get to all of our questions. Last time we did this, we did run over, but we had a lot. But we will look at all the questions. A recording of the webinar will be sent via email to all of those that are registered, and it also will be available after about a week or so on our website. Participants can claim CME credits and complete a personal development activity using the My L3 Plan tool. So for more information on that, please have a look at this QR code. This activity has not been formally reviewed by the CFPC or Royal College, but it is eligible for non-certified credit. And additionally, Main Pro Plus participants may earn additional certified credits by completing a linking learning exercise. So today we are very pleased to welcome back Drs. Jack Rabi and Kathleen Hicks for the second one of these. It's been very highly popular. And they're going to provide an update on the revised provincial guidance for management of hyperbilirubinemia in infants 35 weeks gestation and beyond. So I'm going to start with introducing Dr. Hicks. Katie Hicks is a family doc like me and a certified lactation consultant who's been working in Calgary and surrounding areas for the last 10 years. She has an outpatient practice in Airdrie with focus on prenatal, postpartum, and newborn care. And her inpatient work includes low-risk obstetrical practice at the Peter Lougheed Hospital in Calgary, where she also serves as the site lead for the section of maternal newborn care. And she's excited to be part of this presentation and hopes to bring a community lens to this learning session. And Dr. Rabi joined the Calgary section of newborn critical care as a neonatologist in 2003. He's a professor in pediatrics and serves as the deputy section head of newborn critical care in Calgary. And his primary areas of interest are newborn resuscitation and hyperbilirubinemia. So they've been working closely with the PIN, the Program Improvement and Integration Network, and is grateful for the opportunity to engage with so many valued stakeholders across Alberta to advance our management of jaundice in newborns. So with no further ado, I'm going to hand it over to you guys to pull up your slides and we'll get going. We already have 95 people online, so that's awesome.
Wonderful. Thank you very much, Denise. I'll just share my screen. Okay. There we go. Oh, sorry, let me just get this out of the way. Okay, wonderful. Thank you everyone for joining us today. Looks like we're going to have a wonderful turnout. So we're meeting today to discuss the provincial guidance around jaundice management for babies greater than or equal to 35 weeks gestation. And this project actually launches today. We had a previous presentation about a month ago as well. So let's start off with a bit of background information. On today's presentation, if you look along the left side of every slide, you'll see we're going to track where we are in the presentation so you can follow along. But we're going to be covering some basic background information. We're going to talk about what stays the same and what is new since the last guidance document, where we differ from the AAP 2022 guidelines, which were the basis for the current guidance document. We'll discuss the implementation of risk factors and new graphs, some guidance around supporting families at discharge, and then we'll have a frank discussion around current challenges and future state. We also will leave plenty of time for questions at the end. So how did we arrive here? Well, about 2 years ago, we started working with what at that time was MNC on 2 Alberta Jaundice guidelines. That work has transitioned over to our new PINs, who have been absolutely, the PIN's been absolutely wonderful in supporting our work. Back in the fall, we released the first guidance document, which was specific to babies less than or equal to 35 weeks. And thankfully, that rollout went very smoothly. This is the second rollout, and this one is for babies greater than or equal to 35 weeks. And we're very thankful for the support from the Physician Learning Program in helping us. And one thing we learned from the last time we launched provincial guidance was the incredible importance of trying your best to engage all key stakeholders. And you can imagine when you're taking a provincial approach, that's quite a task. So this project has been going on for 2 years now, and we're very happy to have reached this point. The other reason that we released this guideline later than the first guideline was we knew it would be significantly more complex because the less than 35-week guidelines really apply to in-hospital patients. Whereas when we move over to the bigger babies, now we have to consider what happens at transitions of care around the time of discharge and how we support patients there once they're in the community. So a lot more stakeholders in a more complex workflow. So the objective of this guidance document is to reduce the incidence of severe hyperbilirubinemia and related consequences in newborns greater than or equal to 35 weeks gestational age. Oh, Katie, this is yours. I'm sorry,
okay.
Katie, please.
Yeah, that's exactly what I was going to say. So in order to do this, we're going to have to identify the newborns who are at risk in a timely and accurate manner. We have to provide them the recommended treatment. And we have to ensure that there's appropriate follow-up in the community.
Very good. Thank you, Katie. And, you know, as to how we approach the guidelines, because you may wonder, well, geez, why didn't we just have one document for all gestations? Or why isn't this document more comprehensive going into the science, et cetera? That work has actually been done internationally. We quickly realized that having a single document that covers every scenario that we might anticipate and all the permutations and combinations that entails would be unwieldy. NICE actually published comprehensive guidelines for babies under 35 weeks that we used for that guidance document, and that's 525 pages long. Obviously, when someone is trying to find information on what to do at 3 in the morning, they're not going to want to have to go through 525 pages. So we tried to strike a balance with providing sufficient information, but also make it workable. This is key, and I'd like you to keep this in mind as we progress through the guidance, and that is always, clinical judgment always takes precedence when deciding upon management, and it would trump anything in this guidance document if you feel that it's justified, okay? And also, you'll see that as we go through the document, the guidance, Um, you may see certain statements or recommendations or suggestions and think, well, I don't know if we're able to do that locally. Perhaps you're at a rural site. We've given that a fair bit of thought, and throughout the document, we've tried to make clear that these are our suggestions for how to proceed, but we fully appreciate that our different sites across the province have different resources, different cultures, and different workflows, and that you should do what is best for your site based on the resources that you have available to you. And if you're not able to follow everything in the guidance document, that's understandable. We would just ask that you have mitigation plans in place to deal with any potential problems resulting from that. The AAP, as I said, this guidance document is based on the American Academy of Pediatrics publication from 2022. And I just want to present this one quote taken from that document. The committee recommends caution and incorporation of local expertise in adapting these guidelines for use outside the United States. And we've certainly taken that to heart. And we haven't adopted all of their recommendations word for word. Some we have elected not to. Where we differ, we're going to present that to you so you're clear. So as I had said, these guidelines came out in 2022. This is an update of previous AAP guidelines from 2004, which had formed the basis for our previous guidance. This was put out by the American Academy of Pediatrics and was published in 2022. So how did the AAP go about creating these new guidelines? Well, they state that they incorporated a wealth of new evidence since the previous version in 2004. And we need to be clear about this, there's a large component of expert guidance that goes into their document rather than objective evidence. And they state that new evidence is insufficient to derive specific treatment thresholds. And the committee used the 2004 guidelines as a starting point for their work. Why is that important? Because expert guidance is pretty well the lowest form of evidence that we have if you look at the evidence hierarchy. And the reason we had to rely on expert guidance for this is because trying to answer this question scientifically is very, very, very challenging. And so a lot of it is left, unfortunately, to expert guidance because that's the best option we have. They also reviewed the guidelines from the Northern California Neonatal Consortium and the Academy of Breastfeeding Medicine when they were doing their update. So let's start off with what stays the same. So in the new guidance that's launching today, what is not changing?
So, as you know, we already have a robust screening process to detect hyperbilirubinemia in Alberta. So you can kind of breathe a sigh of relief that many of the steps and the structure of the program remains the same. Would you agree, Jack?
Absolutely.
Yeah. So one, we will have universal screening for newborns for hyperbilirubinemia using either a serum bilirubin or a transcutaneous bilirubin, whatever is available in your area. And we will continue regular screening until the bilirubin reaches a plateau in the first several days after birth.
Thank you, Katie. Okay. So let's go next slide. This is you as well, Katie.
Okay. So we're going to remember that the screening tool is the TCB. So TCB is only a screening tool and is actually not in itself determine the need for phototherapy or exchange transfusion. So if we find high levels of TCB based on our screening, we will order a confirmation TSB to determine the need for treatment. And hopefully with this screening program, we will reduce the number of pokes needed for babies and reduce the incidence of severe hyperbilirubinemia.
Absolutely. Thank you. Excellent. Okay, so let's turn our attention to what is changing, what is new with these new guidelines. So I'm sorry, the slide I know is a little busy. So the main change is that the phototherapy thresholds were raised by a narrow range, meaning there's a higher threshold now at which to begin phototherapy, particularly in the first 72 hours. Now, you might ask yourself, geez, is that a safe thing to do? Are we going to miss babies who perhaps needed treatment because we raised the threshold? So the AAP actually did a follow-up study and they published it in 2004. And it was a retrospective study of 22,000 babies following the implementation of the AAP 2022 guidelines that we're discussing today. And what they found was quite impressive. They found a 47% decrease in phototherapy. So that dropped from 3.9% to 2.1%, and that was significant. They also found that blood draws for bilirubin measurements were reduced by 23%, which is very much in line with what we found in Calgary as well when we implemented TCB screening. And the more impressive part is not only did they reduce the number of blood draws for bili measurements, they did so without seeing any increase in the need for outpatient follow-up TSB measurements. There were no increases in readmissions for babies needing phototherapy. And the only downside is that the length of stay increased. However, on average, it increased by 1 hour, which I don't think is really all that clinically concerning. So I'd say overall, based on this one study, it's very promising. Of course, we need more than one study. So what else is new? Well, as Katie had said, much of the criteria for TCB screening eligibility is unchanged. So still only appropriate for babies less than or equal to 10 days of age. In this case, you can use it for babies greater than or equal to 35 weeks at birth. To be clear, just so there's no confusion, as per our provincial guidance, we are using TCB for babies greater than or equal to 30 weeks at birth, but for the purposes of this guidance document, we're only concerned with greater than or equal to 35 weeks. And it's only appropriate for babies who have not had an exchange transfusion. That part's unchanged. What is new is that previously, once you receive phototherapy, we had advised not to return to using transcutaneous bilirubin readings because the phototherapy blanches the skin and there was concern about getting falsely low readings. However, in the years since the original guidance came out, there have been many studies looking at using transcutaneous bilirubin after phototherapy, and there's a pretty clear signal that if you wait at least 24 hours after having stopped your phototherapy, you can resume using your transcutaneous bilirubin measurements, and the performance is very similar to what it was before phototherapy. So that's the big change, is that you can resume using transcutaneous bilirubin screening after you stop phototherapy, as long as you wait at least 24 hours. The other thing that's new is this escalation of care pathway. And the entire purpose of this is for babies who have high bilirubins or rapidly increasing bilirubins, and you want to do whatever you can to prevent the need for an exchange transfusion in that baby, and certainly to prevent kernicterus, right, or neurodevelopmental injury. So it's triggered by an elevated or rapidly increasing bilirubin and would typically require an NICU admission, some stat baseline lab work. And you'll see we include there total and direct serum bilirubin, CBC, serum albumin. I put a question mark by that, and then chemistries and type and cross match. So this is one of the areas where after discussion with stakeholders, we felt it was fine to differ from the guidance document provided by the AAP. There is very, very poor evidence for the utility of serum albumin in managing hyperbilirubinemia. The item we are interested in is unbound bilirubin that isn't bound to albumin. Unfortunately, the test for that is very difficult to perform, and there isn't a clinical one available. I've seen some work out of Japan, but I haven't seen anything that's been approved for use clinically. And then the other part of the escalation of care pathway is to say that if you are concerned, you should be doing a serum bilirubin at least every 2 hours for the duration of the escalation of care period. And that triggers once you're 35 micromoles per liter below the exchange transfusion threshold. Okay, so where do we differ? So as I said, the AAP made a bunch of suggestions. We took most of them, but some of them we didn't. And I want to be clear on where we differed and how we decided that we were justified in going our own way on a few points here. So for one, I felt that the AAP 2022 guidance put too high of a priority on DAT testing in babies who do not have hyperbilirubinemia. We have many publications that show that the DAT is a very poor screening test. And in fact, it's most impactful when used for a baby who has hyperbilirubinemia that you can't explain, as opposed to using it before the baby develops hyperbilirubinemia. So we put a lower priority on DAT testing as a screening modality, but it certainly still does have a role in diagnosis. As I mentioned previously, we put a lower priority on the utility of serum albumin as a risk factor. Now, we did debate about removing it entirely, but we felt it made the most sense to just leave it as the suite of risk factors so as not to create confusion. What's interesting is they will state that albumin less than 30 grams per liter is a neurotoxicity risk factor. What they don't state is if you actually look at normal albumin levels in healthy newborns, 30 gram per liter is the median, meaning 50% of healthy newborns have an albumin less than 30 grams per liter. So I would argue that it's not a very helpful neurotoxicity risk factor. There seems to be a persistent focus on the utility of visual assessment in the first 24 hours. Again, this is an area that's been studied extensively, and we know that we are not very good at estimating what a baby's bilirubin level is based on how yellow or not yellow they are. And so I worry that if we put too heavy of an emphasis on visual assessment, we may end up with not only false positives, but false negatives as well. So we are saying that absolutely you should still examine and assess your baby, but that visual assessment is supplementary to measuring TSB or TCB. In other words, we should still have universal screening using TCB preferably or TSB. Where else do we differ? Well, the AAP guidance goes on for a bit about community-based guidance outside the immediate newborn period. So what happens if you have a baby who's a few weeks old who is persistently jaundiced? That is beyond the purview of this guidance document, so we didn't go into long-term community-based guidance. We restricted it to the immediate post-discharge period. The other one where we differ, I suspect, is a typo in the document, but they stated that you should stop phototherapy when your total serum bilirubin level has decreased by at least 35 micromoles per liter below the hour-specific threshold at the time of initiation of phototherapy. And that just doesn't make sense. I think what they meant to say is at the time of testing, when you do it, if it's below the threshold by 35, then you can stop phototherapy. The other change we did was we took the AAP graphs, which are actually, I like the work they did on them, but we managed to actually, I think, make them more intuitive. We kind of took them apart and we tried to make both the phototherapy and transfusion thresholds more clear. And I'm going to show you what those graphs look like as well. But the main thing we did was the AAP graphs had multiple lines on them because each graph had 6 different lines on it for each week of gestation. Because we have the benefit of Connect Care, we provide a separate graph for each week of gestation, and Connect Care will auto-select the appropriate graph based on the baby's gestational age. And then the last thing we took out, again, because this is Canada, we don't tend to do, not widely anyways, home-based phototherapy. So we removed guidance around that. Okay, so now risk factors. I know this is a busy slide. I'm sorry. I just wanted to present all the risk factors on one slide for you. Now, the approach here is, and risk factors are always a big thing for our end users. There's two sets of risk factors. There's hyperbilirubinemia risk factors, which is this slide. And then there's risk factors for neurodevelopmental injury resulting from hyperbilirubinemia, which we'll present on the next slide. But for this slide, the presence of any of these risk factors indicates the need for more frequent screening for hyperbili. So just to be very clear, if you have any hyperbilirubinemia risk factors, and there's 11 listed here, the appropriate response is to screen more frequently in those babies. So instead of every 24 hours, you might want to check every 12 hours or every 6 hours, depending on the risks. What are the risks? I'm just going to quickly just run through the topics here. So a lower gestational age, early jaundice in the first day, hemolysis from any cause, though not necessarily confirmed, just known or possibly even suspected. A family history of a sibling or parent needing phototherapy or exchange, a family history of genetic ancestry of red cell disorders, scalp hematoma or bruising, trisomy 21, macrosomic infant of a diabetic mother. If you're sending the baby home and they're close to the photo threshold, that's a risk factor. If they receive phototherapy during their initial hospitalization, that's a risk factor. And then exclusive breastfeeding, but specifically with suboptimal intake. And I want to be very clear on that point. We tried to be very clear in our support for breastfeeding and continuing breastfeeding even when a baby is jaundiced, if at all possible. Okay, so we were talking about the hyperbili risk factors. Now these are the next set of risk factors, the neurotoxicity impairment risk factors. Okay, and these are really, you see there's only 5 of them, and they're really a subset for the most part of the previous risk factors, but just a more extreme version of them. So whereas the other one said for hyperbili risk factors, a risk factor was prematurity. Here we're specifically, or sorry, a lower gestational age. Here we're specifically saying less than 38 weeks. Also, the previous one had suspected hemolysis. This one has confirmed hemolysis. The presence of sepsis, significant clinical stability in the previous 24 hours. And I put a question mark there because this is one we've received questions about. Fair enough. What does that mean? Significant clinical instability. We left it vague on purpose because the number of conditions that you could consider under this umbrella term is vast. But we're looking for things like, you know, baby's not feeding well and is having hypoglycemia. The baby is hypotonic, anything that would have you concerned about the baby. And then, of course, the albumin, low albumin, which we discussed. So again, how do risk factors guide behavior? Well, as we said, the hyperbili risk factors will determine how frequently you check. And the hyperbili neurotoxicity risk factors will determine at what level you act. They'll adjust the threshold for action. Okay. And now let's have a look at the new graph. So this is what the graph looks like from the publication, the AAP graph initially. This is unedited. So you can see that there are 6 lines here, one for each week of gestation. And they had 4 graphs. So they had one graph for photo thresholds without hyperbili neurotoxicity risk factors, one for photo thresholds with these risk factors, and then one for exchange transfusion with risk factors and without risk factors. And you can see that the key here is the neurotoxicity risk factors. Okay, so what are they going to look like for us? So we took this and took the information out and rebuilt the graphs in a way we felt was probably, hopefully, more intuitive, and in that it will help to simplify interpretation. It will auto-select, Connect Care will auto-select the correct graph for the baby's gestation. Both your TCB data points, which are entered using the AGIS POC module, and your TSB data points, which will flow in automatically, are automatically plotted on the graph for you. One of the big advances that we have here is that working with the Connect Care team, the graphs will now show you when the baby received phototherapy by highlighting that portion of the graph in blue and showing you, based on how many light bulbs there are, how many devices the baby had on them for that period of phototherapy. And then the other thing that's going to be added, and we'll demo this, is that for any data point, if you hover over it, it will calculate for you how far away from the treatment threshold, either phototherapy or exchange transfusion, that you are. So it might say you're 50 below, or it might say you're 50 above, in which case it would be highlighted in red to draw your attention to it. So here's what the graph looks like zoomed out. I'm going to give you a zoomed in version, but the key here I want you to take home is it's really the first 4 days where we see this kind of increase in our thresholds. And then you'll notice it's just a straight line out to infinity. This isn't because, in my humble opinion, this is what's happening physiologically. This is just, again, a limitation of our data that we have. But you can see on this graph that there is a period here. You can see the baby was under phototherapy with the blue, and you can see the baby was under one phototherapy device. Hovering over this one data point, it gives you the value. It shows you what the threshold is for transfusion, exchange transfusion, and phototherapy. And in this case, it highlighted the phototherapy values because you are actually over the threshold for this baby. Okay. This is a zoomed in version, just so you can see that a little bit more clearly. Okay. One question that might come up is, you remember at the start, I mentioned that one of the changes is they raised these thresholds here. They're higher than they used to be. And of course, concerned that that might be associated with harm. They stated that they felt justified in raising the thresholds based on new evidence that bilirubin neurotoxicity does not occur until concentrations well above the 2004 exchange transfusion thresholds. So they felt they were justified in raising them. Again, this is just for those who might be familiar with the previous graph we used. This was the previous one. It was published in the, it was endorsed by the Canadian Pediatric Society, but this is the 2004 AAP graph. And this is the new graph here on the right. Okay, now, one of the major changes, and Katie's going to speak to this now, one of the major changes with this guidance is we actually endeavored to provide some guidance around how to support families and babies and our colleagues around the time of discharge to the community. And this is part of that. So all yours, Katie.
Yeah, so when a baby's ready for discharge, we need to have a follow-up plan for screening in the community. It's a topic that's near and dear to my heart because I'm one of the people that sees these babies in the community. So this graph is actually quite helpful for when you're able or you're preparing to discharge a baby who has not had phototherapy. So we don't really need to go over it all in detail, but you can see that based on the level of the bilirubin and the age of the baby at discharge, it gives you a little bit of guidance as to how soon the baby needs to be retested once they've been discharged. So I find that quite helpful because sometimes it's a little bit ambiguous as to what you kind of just take a guess of what you should do based on the Billy, and this just it's a little bit more prescriptive in that way. And these are the risk factors that for babies that have had phototherapy. So these risk factors for rebound are important to note, just to be able to make a plan for these babies in the community and possibly provide them with requisition or a really concrete discharge plan, because they're more at risk for rebound hyperbilirubinemia.
Thank you, Katie.
And this kind of goes without saying, but it's really important to emphasize that if you've identified that the baby needs follow-up in the community, the onus is kind of on you to make sure that follow-up is in place.
Yeah.
We're lucky in this province to have such a strong public health system who sees the majority of these babies. But if we're making a plan with a family doctor, but the patient doesn't have one, potentially we have to make an alternate plan so that these babies don't fall through the cracks.
Absolutely.
And finally, the families need to know what to do when they're taking their babies home, especially if they're at risk for hyperbilirubinemia. So, describing the signs and symptoms of hyperbilirubinemia that would prompt the families to bring their babies back into care at the hospital is important. And also just providing them with the plan for follow-up, whether it be public health or with their midwife, their family doctor, and if necessary, giving them even a requisition or a follow-up plan for TCB so that they have this follow-up plan in place.
Thank you, Katie. I'd like to take the opportunity to also highlight the critical role, as Katie had alluded to, of public health. And they really are a program pillar. Our approach to jaundice has been recognized internationally and as a model for how to do this. And a major part of that is public health. We simply couldn't do this without them. They have a greater than 90% follow-up rate after discharge, which is incredible. Public health nurse resources differ across the province, and that can create some confusion sometimes because those in the North Zone, for example, have different resources. I don't know if different resource is the right way to say it, but different workflows than those in the South. There's some differences in access to TCB meters across the province, especially with some of our rural partners. And one thing we learned quickly was the ability to collect lab specimens varies depending on where the patient is discharged home. Some places don't have access on weekends or after hours, which can create challenges around discharge and certainly can create confusion for the public health nurse as well. So with this version of the document, we worked closely with public health to make sure that the guidance was much more clearly laid out. And this last point, I just want to put a caveat there. So as an example of how workflows differ across the province. So in North Zone, public health is actually able to go to a patient house, draw the TSB, so a serum billy, and then have it run. That is not the workflow in the South. It would require working with a physician or a midwife to get those orders put in. And the other piece I want to highlight is in Calgary Zone, for example, when if a baby goes home and then gets readmitted to the hospital, so it's the second hospital admission for jaundice and then goes home, we don't have the ability in the South to follow them after they are discharged that second time. But my understanding is that in North Zone, they are able to do that. So certainly there's still some differences across the province, which we need to be aware of. And of course, we couldn't have this talk without mentioning our midwifery colleagues. And they've been on board with this project as well. And this is provided from the midwifery section, which they kindly put together. Infants born at home should have bilirubin testing between 24 and 48 hours after birth. That's per the AAP guidelines. Close follow-up with home visits during the first week after birth. And then midwifery will assess them within 24 to 48 hours of discharge from hospital. So excellent community follow-up. Similar to what we said with public health, their access to different ways of measuring bilirubin are going to differ across communities as well. And midwives often collect the total serum bilirubin blood draw themselves and or DAT specimens during client visits. And they may collaborate with local public health and outpatient labs to ensure timely follow-up of bilirubin levels. So with that, we'll move on to the last part of the talk because we want to have plenty of time for questions and feedback. So first off, I have to be open here about challenges, right? There's always challenges with large scale projects like this. So the first one was the fact that we had a staggered rollout with the less than 35-week guidance in the fall and the greater than 35-week guidance today. We were concerned that might actually be a source of confusion for people. However, it actually went very smoothly. I'm happy to report, and was readily accepted as well by our stakeholders. Areas for confusion with this rollout potentially? Well, yes. Calgary has our own TCB graphs that we create in-house. And the reason we create those locally and don't share them provincially is because it's based on the performance of our local labs as well. So we work closely with the labs, and we don't have the capacity to do that on a provincial basis. However, we felt that with these changes, the risk for patient harm was low. The higher risk was causing confusion or frustration with our healthcare providers. So far, so good, but we'll keep reaching out. The other area that caused a bit of confusion was around checking the irradiance of our phototherapy devices. So how intense is the light that we are providing to the babies? And what we had learned was each manufacturer of phototherapy equipment, so the lights that we use, each manufacturer has a specific approved meter that should be used to measure the irradiance of the light. So in other words, it's not appropriate to use the approved irradiance meter that one manufacturer recommends on another manufacturer's phototherapy device. So we are in the process of trying to collect all that information in terms of, we've already started the work of seeing what the equipment looks like across the province in terms of what meters we have and what light devices we have. And now what we're doing is working with local teams to dig into that guidance from the manufacturer and pull out what their recommended irradiance is, because each manufacturer will have a different recommended irradiance. And then the hope will be that we will have that available online and then link to it from the guidance document, but that's still in process. And then what challenges do we have potentially that are specific to Alberta? Well, one that we have, and I've gotten some pushback, mainly from my neonatology colleagues, which I completely understand. One of the things recommended in the guidance as per the AAP is once you start phototherapy on a baby, you should do a TSB within 12 hours to document a mid-therapy decline. Now, some people feel that this is overly prescriptive and that not everyone needs to have that TSB at 12 hours. It might be okay to wait 24 hours. So what we did was we included the guidance of within 12 hours, but as I had said previously, throughout the document, we're also clear that if based on your clinical assessment, you feel this is not appropriate, that you should do what you feel is clinically appropriate for the patient. The other thing we're trying to discourage, and I think we're getting some traction on, is stopping the practice of clinicians ordering a total serum bilirubin instead of a TCB because they think the infant is at higher risk. The correct approach is still to do universal screening with TCB if you have it available, and if not, with a TSB. And then, of course, the ongoing challenge of resource distribution across the province, things like who has access to TCB meters, etc. So what does the future hold for us? Well, we do have a plan in place for ongoing surveillance with iterative changes in response to data and feedback. So we have a planned formal assessment after 24 months. We are going to seek end user and family feedback, look at the clinical effectiveness, and do a cost assessment. We actually have a meeting coming up shortly on that. And then any work in response to feedback from our RNs or LPNs in terms of ease of interpretation of the graphs and workflow for MRHP notification. And that's an area where there have been questions as well around, is the nurse able to decide if the TSB should be drawn in the middle of the night based on the TCB, or does the nurse need to contact the MRHP in the middle of the night for that? And then around optimization, I can tell you we've already started a lot of the optimization work and plan to roll out some of these changes in the coming months. So one area is continue to work on increasing the functionality of our bilirubin graphs. So we've already shown you some of the changes we've made in terms of phototherapy and how far away you are from thresholds. Another thing we've been working on for over a year and a half now is to come up with a Connect Care solution to ease our ability to track patients after discharge into the community, to see if they actually had the testing done that we'd suggested and what the results are and if action is needed. It was one thing for us to recommend that, the MRHP should follow these patients into the community to make sure there's a smooth transition. But of course, we can ask that, but if we don't provide the clinicians with a tool to be able to do that, then it's not really a fair ask. So this tool hopefully will meet that need, but we still have some end user testing to do. Of course, ongoing addressing differential access to resources across the province in our different communities, and then trying to get some alignment around the spectral irradiance meters and the need to have several different meters. So in summary, we are launching the new guidance document today. And in terms of what's new, you'll be able to resume TCB screening 24 hours after completing phototherapy. There are new risk factors for hyperbilirubinemia, which help determine how often to test. And there are risk factors for hyperbilirubinemia neurotoxicity, which tells you at what level to intervene. The phototherapy thresholds have been raised by a modest amount, hopefully leading to fewer pokes for our babies, and we have new graphs. So with that, I'll bring the talk to an end. I just want to say thank you so much to our PIN, our child health PIN. Pamela Baines has been absolutely amazing in moving this along, and Christine Oakley has recently left us for more exciting opportunities, but have to acknowledge her support as well. Thank you to the Physician Learning Program for helping us get the word out. And many, many, many thank yous to our many multidisciplinary provincial stakeholders, including nurses and educators and managers, our many physicians, our lab partners in public health and midwifery, and of course, Connect Care. So with that, we'll open it up for discussion.
Awesome. I'm glad we have time because we have oodles of questions. Thanks, folks, for upvoting. So please go through and upvote questions you want. So the first one from Nicole has been quite upvoted. And it's the guidelines doesn't specifically speak to the frequency of screening with risk factors. It was mentioned Q 6 to 12 hours versus Q 24 hours. Is this just based on clinical judgment by the MRHP or by nursing, or how should that be operationalized?
So excellent question. And this is what I was trying to, thank you for the question, by the way. This is what I was trying to get at the start when I was mentioning that there are so many permutations and combinations to try and consider that it would be next to impossible to say, look, if you had of these 11 risk factors, if you had the first risk factor and the fifth, you should do it every 6 hours. If you had 3 of them, you should do it every 4 hours. You can see how quickly that would become unwieldy. So the general recommendation is that you should screen by 24 hours for babies without risk factors. If they have significant risk factors, do it sooner. How much sooner? 6 to 12 hours is very reasonable. The beauty of having TCB as a screening tool is it's very low cost, relatively resource non-intensive in terms of nursing time, and relatively accurate. So you can screen more often. So even if you want to screen every 4 hours, for example, until you're confident at the rate of rise. And that's what you want to see is that pattern. But I can't come out and say, specifically, oh, you should do this at 8 hours or you should do this at 4 hours. You should do it more often. Now, I want to ease any concern you might have there about, because of course the concern is, well, geez, what if we miss it, right? What if we didn't do it soon enough and it climbed pretty high? We are dealing with babies greater than or equal to 35 weeks here. So the level of bilirubin that you would need to actually see injury is very, very high and well above our initial treatment thresholds. So there are fudge factors built into the guidance such that even if you're above the phototherapy threshold by a little bit, in terms of safety for the baby, it should be safe. So I don't want people to worry that perhaps the baby was a few over the threshold and we didn't test sooner. That shouldn't have any implications in terms of the baby's long-term outcome.
Okay, and a related question from Dina is just to clarify regarding 2.2 in the guideline. We will screen all newborns who are under 40 weeks gestation at 12 hours with TCB due to the risk factor of lower gestational age. It's a question.
Yeah, again, yes. Thank you for that question. So yes, they do say that if you are under 40 weeks, that is a risk factor for hyperbilirubinemia. If you're under 38 weeks, that's a risk factor for hyperbilirubinemia neurotoxicity. So according to those guidelines, yes, if you are under 40 weeks, you should be, well, actually, let me double check. Is it 40 weeks? Yeah, it is 40 weeks, I remember. You should be checking. And you know what? That might be, sorry, I'm trying to get out of my slideshow here. That might be overkill, to be honest with you. And we may end up deciding that we don't need to do that. And that is why we kind of had that approach of assessing our outcomes and looking to see how it performs. We thought it's safest where we could to adhere to the guidance as provided by the AAP, unless we had a good reason to deviate from it. So I agree with you. This will result in more screening, but hopefully not in more blood tests. If we see that it becomes onerous based on your feedback, that's something we can revisit during the optimization and look at it, adjusting that guidance. Yeah.
Mm-hmm. And then Dina, you had a related question, but I think we've covered it. Can you just have a look and make sure that that your second question was addressed? And we'll just pivot here to Cassandra, who says, if we're completing a TSB at home between 24 and 48 hours as a registered midwife, where can we find the graphs to determine which risk zone the baby's in? We will not be able to use the Connect Care graph because the baby will have been discharged. Cassandra says she's been using Billy tool, which uses the AAP guidelines. Do we have access to the Alberta graphs elsewhere?
So yeah, thank you for that question. So the graphs are included in the guidance document. And so if you like, you can simply print them off as well and have a hard copy with you. And that's something certainly we've discussed with some of our family physicians who are outside of an acute care setting and may not have ready access to Connect Care. You can print off the graphs if you want to have a hard copy. Apart from that, the workflow, I had mentioned before that we have come up with a workflow to be able to track patients into the community. Again, that's something you need access to Connect Care for, but that will actually pull up the graphs for you as well, even if they're in the community. But it sounds like you don't have access to that. So I think the best option, I would say, is to use the hard copy. I wouldn't necessarily advocate for using the Billy tool or any of those other ones because I'm not sure how they're updated, and so I can't really speak to them. But
I
yeah,
will say that I printed off those graphs and laminated them in my office, and they're on the little ring thing now. So if based on the gestation, I just have them there to use. Because I actually do have access to Connect Care, but at the office, it's not really feasible to log on to it. And I know many family docs don't have access at all.
Kathleen, if you wanted to, we could include that with the pearls document for everybody.
That
So
I
that
mean,
just
that it's
laminate
I think it's a really important thing for the family docs and midwives, obviously, just because they don't have access to Connect Care at all.
Yeah, Cassandra's just following up and saying, please, if she'd love to have a link for that, and please send. So, okay, that'd be great. So, Joanna has an interesting question around the rate of rise that you mentioned, where she notes that currently some babies are being discharged with a single green zone Billy, and wonders if babies with any risk factors such as bruising secondary to a vacuum have at least 2 TCBs to demonstrate rate of rise.
good question. There isn't specific guidance around that point, but I appreciate the importance of the point. It's always nice to have multiple data points if you can, so that you can look at rate of rise. However, if you have a baby who is otherwise relatively well, I guess the key is I wouldn't advocate for keeping a well baby in hospital longer just to get additional TCBs unless there are significant risk factors or risk factors for readmission. And if you may recall, we provide some guidance around risk factors for readmission to hospital as well.
Okay. And then a couple logistical questions. So Jennifer just wanted to clarify, and I think this was covered, that gestational age is already accounted for in the graphs, even though it's a risk factor. So you have separate graphs for each gestational age, correct?
We do. So yes, we split them apart and the risk factors are incorporated. The gestational age risk factor is incorporated into the lines already. Yes.
Okay. And then Julie has a question about whether or not the risk factors will still be listed at the bottom of the phototherapy graph on Connect Care.
They will be. And I just massaged the wording recently. Yes, they will be. We'll have both sets of risk factors available at the bottom of the graph. Yep.
Okay. And then Krista has a few questions. So the first is just how accurate is the TCB, and notes that historically she's found it to be really different from the TSB.
Right. What a great question. This is a very challenging area of science, and that is because we treat the total serum bilirubin as the gold standard test. You know, this is the accurate test. This is the source of truth. In fact, that can be off by, plus or minus 10%. The allowable variance in performance for TSB is quite wide. And so when there is a difference between a TSB and a TCB, we just assume that the TCB is wrong. But it could very well be that the TCB is actually accurate and the TSB is wrong. However, for now, just to be clear, so there's no confusion, we use the TSB to make treatment decisions. The gold standard test for bilirubin is actually high performance liquid chromatography, which is really the purview of research labs and isn't available for routine clinical use. So we're left with this imperfect test called the TSB. And so when you see that variance between the TSB and the TCB, use the TSB as a source of truth, but be aware that it is also quite imprecise. I hope that answers the question.
Mm-hmm. And then the second question was whether there's a good patient handout already in Connect Care.
Oh, sorry. Yes, I'm sorry. Yes. Let me come back to the last point. I'm sorry. I knew there was one more thing I wanted to say on that. The other piece about TSB measurements is that we actually met with the lab and looked at the different TSB testing devices that we have across the province. We have a list of all the devices. And it turns out that different devices give different results, and it can be significant. So, we found, for example, in Calgary zone that the TSB testing methodology or the devices they use at community labs is different from that used in hospital labs. And the community lab tests tend to read significantly higher than the hospital lab tests. Again, if you get a difference there with the TCB, is it because of the TCB or because of the TSB? Just to keep in mind that the TSB is an imperfect test, but it's the best we have, and it's going to be our source of truth going forward. I'm sorry. You were asking then about the
Is there a patient handout available in Connect Care?
Oh, a patient handout. We have handouts for staff. I don't think we have a patient handout, actually. Let's put a little asterisk by that and we'll work on that.
Yeah, that sounds like something we need to do.
Yeah,
Awesome.
thank you.
And then the last question here was whether the order set had been updated so nursing can order the TSB if indicated without calling for the order. So a protocol in place so that they're covered, i.e. cut down on calls that are not necessary.
Yeah, we thank you for that question. It's such an important point, and I can tell you we've had many conversations about this. So I can tell you initially, the first version of the guidance document advocated for nursing to contact the most responsible health provider if they wanted to draw a TSB. Then we got very strong feedback from different communities across Alberta saying, please, no, that doesn't work with us. We have, one physician who is on for a week at a time. We can't be waking her up 3-4 times a night with a bilirubin. It's just not workable. We have a workflow that works for us, but please take that out because it doesn't allow us to do that. So it's very tough to find, a balance that everyone is happy with. So what we ended up settling on is the guidance document does suggest that the MRHP is the person that should order the TSB. However, as I'd said before, we leave it open to local resources and local cultures. So the intent of the document is to say, if your workflow would better support having the MRHP enter in the order, regardless of the time, then let's go with that approach for your site or your region. If, however, you have a historical workflow where nursing makes that decision and you have protocols in place to support that or documents in place to support that, then by all means, let's do that. We don't want the guidance document to be an impediment to what you do, right? We want it to support it, but it's very difficult to incorporate everyone's differing perspectives and needs into one document. So we tried to give some leeway as best we could there.
Okay. So Camille has a question. She just wants to confirm that this guideline and graph are for both newborns in hospital and newborns returning to the emergency department. As previously, we had 2 separate guidelines.
Yes, that is correct. It applies to both. Yeah.
Okay. The next one is from Jacqueline, and she's wondering about how this is going to be communicated to community and acute care physicians. She notes in urban Calgary zones have the TCB for 20 years, and she's a rural public health nurse. So many physicians, hospital, and communities still expect rural infants to have access to TCBs. I think this gets into your comments around there's variability, right?
Yeah, there absolutely is. And, we've certainly tried our best to communicate this. We've been working at it for about 6 months now, trying to get the word out, meeting with stakeholders. If there is a group that you're aware that we missed, I would ask you please, as a partner, to let us know so we can reach out to them, because we would hate to miss anyone. But we tried to be as thorough and comprehensive as we could in getting the word out.
Mm-hmm. Okay. So yeah, both Brenna and Krista are talking about handouts in Connect Care related to newborn jaundice care instructions, but they both wonder whether or not they've been reviewed and updated for this new guidance.
I would have to take a look at that. We do have a part of our team that is dealing with online documentation and making sure it's all updated. And the last I heard, we were all good, but I can go back and take a look at that specifically.
Okay, perfect. And then Nicole has a few comments. One is on figure 1, whether the reference for home phototherapy will be removed.
Figure 1. Okay, let me pull up figure 1 really quick here. So at the start of the presentation? Or are you talking about in the guidance document?
Probably in the guidance document, I would guess.
Oh, I'm sorry. In figure 1, there's a reference to home phototherapy. Then yes, we will thank you for alerting us to that. I will have a look at that. That shouldn't be in there. Yeah.
Awesome. And then she's also commenting that she can't find in this version of the guideline where it states that a TCB should be done prior to or within a certain amount of time of discharge. Notes that she notes previously it was current within 12 hours of discharge.
Right.
That's now a question.
Yeah, great question. Thank you. So around discharge, the guidance around when to recheck is provided based on whether the child received phototherapy during their initial visit or not. There's 2 sets of recommendations there that Kathleen had presented, and they're in the guidance. So it will specifically say once the child goes home, if they have phototherapy, and then it'll give you some different scenarios and with recommendations for when you should test when the baby goes home.
I think she was commenting on how much time before discharge rather than after.
Oh, I'm sorry. What was that, Denise?
I think she was commenting on how much time before, that it used to say that it had to be done prior to discharge within a certain time window.
I see. Yeah. No, I don't believe, thank you, Nicole. I don't believe that we provide guidance around that. I believe the guidance is just, we want universal screening. So every baby should have at least one, and then one TCB, and then every 24 hours thereafter, if they don't have risk factors, until they go home. But we're not going to say that as long as the child has that one, we're not going to then say, well, you have to have one within X number of hours of discharge. Yeah, I think that would be too prescriptive.
Okay. And then Julie has a question about whether all sites will use the same graph based on gestational age, or will rural sites be using graphs with lower thresholds as we do now for TCBs?
Very interesting.
Like...
No, yeah. My God, I love these questions. You get so many perspectives from across the province. No, the intent of this guidance document is to apply universally to the entire province, rural and urban.
Okay. And then Charlotte sort of has a follow-up related question to that around, are there any recommendations to compare TCB and TSB for particular neonates, as some have large discrepancies? I think you've commented on that a little bit, but how do people handle that?
It's a great question. This is an issue that we recognize. So specifically, what we've noticed, and this is in the literature, is that babies with darker skin tend to have falsely high readings. And so it can become a bit of a pain because, one of the great benefits of TCB is avoiding pokes. But if every time you do a TCB, you get a falsely high reading and end up poking the baby, you're going to end up poking the baby more than you would have otherwise. So it's kind of counterintuitive. So there is nothing in the literature currently that I'm aware of that would lead us to say, okay, if you're dark skinned, then introduce this fudge factor, take this much off, for example, that we can do safely. So what I have been recommending to colleagues is if you have a baby where you have done the TCB and it's high, say in the red zone, and then you do the TSB and it's fine. If that happens twice in a row on that baby, then I stop doing TCB measurements on that baby and I rely on TSB because I can still monitor the baby safely and hopefully end up with fewer pokes. In terms of a safety perspective, because it's overreading with dark-skinned babies, it's not unsafe, meaning we're not going to get we're not expecting to see more false negatives and missing kids. What it does mean is we're going to overcall and poke kids unnecessarily. So not ideal, but also not unsafe. That's not something that we have the capacity to change in terms of how the meter is functioning. We have reached out to the manufacturer about that, but we just have to wait for the technology to advance in that area.
And then Patricia has a follow-up question that I think you commented on a little bit in your remarks, but it's a change so in practice. So she says, currently the CPS guideline establishes follow-up based on whether it's DAT positive when the TSB is high, intermediate, or high. And when the DAT is negative, it will not require further testing or more pokes. Do we now not consider a positive DAT a risk factor?
Well, a positive DAT can be a risk factor if you have that it's documented as positive. But we have moved away from those CPS guidelines because they are, goodness, if I remember correctly, I think they're over 20 years old now or coming up on 20 years. Now, I have been hearing for the last 2 years that the CPS is doing some very exciting work on new guidelines. I just checked a month ago. They're still not up. But I'm very curious to see what they're going to be. I have been told unofficially they are also going to be based on the AAP 2022 publication. So I'm hoping we'll be well aligned. But if there are any glaring discrepancies between what we have now and the CPS guidelines, when they do come out, hopefully in the near future, we'll certainly address them at that point.
So for right now, sticking with the AAP 2022.
Exactly.
And so Brenna has the last question, I think, which is just what resources will be available for Connect Care downtime or documenting TCBs and plotting TCBs and TSBs on the appropriate graph.
Excellent. I know we've actually done work in this area, and my understanding from Pamela is we actually do have a downtime procedure for this. And I think there's a little package that they put together. And we can certainly share that if people would like.
And Tracy had to squeeze in there with the last one, I think so, which is there a change to the frequency of serum Billy sampling, i.e. SB is predictive times 24 hours, so the TCB is not relevant after a serum is done.
Ooh, I didn't understand the last part there. Sorry.
So I'm not sure I do either. I think Tracy, correct me if I'm saying this wrong. So she's giving the example of a serum bilirubin is predictive for 24 hours. So the cutaneous bili is not relevant if a serum has been done.
Well, I think I agree with the yeah. Let me see how to address that. The TCB is our screening test. It is not a diagnostic test. So the TCB would never guide treatment in terms of should we start phototherapy or do an exchange transfusion. All the TCB tells you is whether or not you should do a TSB. And then the TSB would then be used to make that decision around phototherapy or exchange transfusion. Oh, did we lose everyone?
No, they just turned off the evaluations.
Okay.
So I think that's it, and we were still a quarter of an hour over, but I think it was so engaging. We lost a few people, but I think there was still lots of people eager for the questions. So thank you so much to everybody who attended today.